Fulvio. Thank you for joining us for the next webinar in our One Chancery Lane weekly webinar series. Today's webinar is about cosmetic surgery claims from a legal and clinical perspective. And I'm absolutely delighted to be joined by Fulvio Urso-Baiarda, who is a renowned consultant plastic surgeon and is truly a leader in his field. And he's won Cosmetic Surgeon of the Year previously. In the course of the webinar, we're going to look at common cosmetic surgery treatments, areas of poor practice that us as practitioners can look out for. Fulvio will also deal with consent, which, as many of you know, is a huge issue in this area, particularly because patients don't have to have this type of surgery. It's an elective choice. But indeed, we'll also be looking at high expectations. As we all know, some patients do have very high expectations of what they expect, and types of surgical outcome. During the webinar, you can send your questions to us, and there is a Q&A button at the bottom, so you can pop your questions in there and you can submit those, and we'll try and deal with those as we go along. Alternatively, you can ask questions at the end, and there will be an opportunity to do that then. So I guess that means it's time to hand over to you, Fulvio.
Over to me. Thank you so much, Dominique. And thank you very much for asking me to do this. It's an absolute pleasure and a delight. And I can now see the number of participants, and I'm slightly amazed. So I will try to make it good value for you. Thank you for giving your very valuable time. As Dominique said, so I'm a plastic surgeon, and my practice has gone from, over the last 5 or 6 years, being primarily a reconstructive surgeon, doing things like head and neck reconstruction, breast reconstruction, abdominal wall, putting limbs back on if they've come detached through mishaps, with maybe a 5% aesthetic practice, to really flipping that on its head. And I'm now 95% aesthetic and 5% reconstructive and other, really. And I guess it's market forces that have largely dictated that. I do love aesthetic practice, though. I genuinely love it, and I'm very much living my my aspirations, what I'd like to be and like to do. So I think you find some practitioners who fall into it, and I've very much taken myself here. I love this quote: "An expert's a person who's made all the mistakes that can be made in a very narrow field." And I have a great recognition and sometimes a personal relationship with some of the complications that I see in my medical legal practice. I have to say, a medical legal practice has been really helpful in allowing me to live some of those mistakes vicariously and sort of preempt them and change my practice around them. But everyone gets complications. Any surgeon who says they don't is out and out lying, I would say. We know we all get them. So a bit about my background. I won't labor this too long. I graduated in 1999 from Oxford, and I then, over the next, quite a lot of years, did a whole load of posts culminating in completion of higher surgical training in plastic surgery. They weren't all plastic surgery jobs, but actually from 2004, they were all plastic surgery jobs. But up to that point, you get a sort of grounding in experience, including plastic surgery, but also, in my case, general surgery, vascular surgery, intensive care. I worked in intensive care for a while, which came in more handy than I thought it would around COVID. During that period, I got a couple of other degrees as well. And in 2012, I was still working during that time. 2012, I got the FOS class, which designates me a plastic surgeon. And this will be relevant because the field of aesthetic surgery does not need to be conducted by plastic surgeons. It can be conducted by a cosmetic surgeon, which is a self-designated title because there is no Royal College of Cosmetic Surgery. So it is not illegal for any doctor to call themselves a cosmetic surgeon, but it is very wrong for a non-plastic surgeon to call themselves a plastic surgeon. And the difference between the two titles, I often glibly put it, is about 13 years. Then there were a few fellowships I did. I maybe did a few more than some, but it's typical to do fellowships at the end of training. Became an NHS consultant then. Dominique mentioned the Cosmetic Surgeon of the Year, which is a bit of a surprise because, as I alluded to, I didn't really regard myself as a cosmetic surgeon when I got that. But I suppose cosmetic surgery is a subset of my practice. I do a lot of medical legal work, but interestingly, the commonest thing I report on is related to breast augmentation surgery. Amongst my industry, we know of the augmentation mastopexy, the single stage breast augmentation with an uplift, to be the most litigated cosmetic procedure of all. It's one of the most challenging, and I can explain why that's the case, but it's highly litigated, and the more medical legal work I do, the more I see that actually the cause of those litigations is often the surgeon actually shying away from what needs to be done. So not doing an augmentation mastopexy when it was needed, or doing one but not really going for it and doing a bit of one and a slightly half-hearted one. But actually, if you just recognize you need to do it and do it, it's technically not particularly challenging if you have the skill set for the other stuff that we commonly do. And then some of these other things, facelift blepharoplasty is much less common in my medical legal practice, but it also probably reflects the fact that they're less common in my clinical practice too, and so on. I'm usually approached by way of an informal tabletop report first, and mine are very informal. It's an email to me. It'll be a very quick fire email back. It's usually a line or two, and I'll say whether I think it's greater than 50% prospects of successful failure and why, and that's it. And I may never hear from that person again, or they may come back to me. I tend to decline around 40% of cases that I'm approached with, either because it's not within my expertise, or I think it has poor prospects, or I have a conflict of interest. And my threshold for considering myself to have a conflict of interest is extremely low. If I would know that person well enough to chat with them in a bar, then I consider myself probably conflicted. And it doesn't matter if I like them or dislike them, either way is a conflict. So that's about me. Right, so this talk today will be about common themes that I have recognized in my medical legal practice, and what I have formulated as my views on what makes strong practice or weak practice. I'm going to pepper spray this with clinical examples throughout, because I think that just gives you a real flavor of what's behind what we're talking about. This is the Archangel Michael defeating Satan, and this is a theme that you're going to see throughout, the sort of the devil and the angel on one shoulder. And the common themes I'll talk about really break down in a sort of systematic way. And when I'm looking at a case I've been asked to look at, I think about these things quite systematically. So first of all, is the setting correct? Is the background correct? So the background is the practitioner and the practice. The practitioner needs to be qualified, and the place of practice needs to be suitable for it. And a place that is suitable for one thing may not be suitable for another. So even an all singing, all dancing operating theatre may not be right for some things. It's uncommon in the aesthetic field, but you might require an intensive care or provision for HDU afterwards. Like I say, uncommon in the aesthetic world. And if it doesn't have it, then it's not appropriate. Or indeed, it may be too higher a facility, and not have some of the things that you would get in a clinical setting, in a clinic setting. So it has to be judged by what procedure is being done. Next, I consider the preamble to surgery, the decision-making, consent, explanations, then the actual technical conduct of the surgery itself, and finally, what aftercare is provided. It's not uncommon for several of these. I don't know if I've had a clean sweep of all four being, having been critical of all four, but certainly it's not uncommon for there to be more than one factor. Absolutely, that's typical in fact. Right, so first of all, I said with setting the scene, it relates to the practitioner or the institution. And in relation to the practitioner, most practitioners set out to do a good job. I truly believe that. They are a professional body and most behave professionally. Most meet the legal minimum requirements to perform this kind of work. Most do not falsely claim qualifications, although the sort of softer aggrandizement of qualifications is more common, and the sort of, you know, is this misleading? By the strict, you know, letter of what they've said, it's correct, but it's implying things, and I see implication of things a lot more commonly, but most do not falsely claim explicitly qualifications that they have. And most are adequately experienced to provide the treatment they're doing and aim to provide good care. And having said what I said earlier about complications happening, actually that's okay, and complications happen, but as long as you are providing good care every step of the way, most patients nonetheless have a good experience. And I can think of one of my own patients who was a post-massive weight loss patient, and they're very high risk for complications of many kinds. And she also wanted a number of surgeries, and I operated on her abdominal wall, breasts, arms, thighs. And this poor lady kept having complications along the way. She really ran into things, and we dealt with them and we got through them one at a time. And it was a real process, and it took a lot longer than it would normally have taken. And at the end of it, she said, look, I just really want to thank you for looking after me so well. And I could have fallen over because I thought she would have I knew she had 3 large sons as it happens, and I thought they would have probably wanted to murder me. But she said, no, I've always felt looked after, I've always felt cared for, and that's all you want, really. I knew I was high risk, you explained that to me. So that is on the good side, I'd say, actually looking after people, irrespective of what happens. The themes that I see relating to the practitioner, though, is, and the sort of summarizes the have-a-go practitioner, the have-a-go cosmetic practitioner, because I said at the outset that this is something that I really love and really enjoy doing and really want to do professionally. You find a substantial number of practitioners in this field who do this as a bolt-on to what they really enjoy doing for extra income. And they don't seem to sometimes to give it the respect that it needs. I, again, know when I was a trainee, an excellent head and neck surgeon. His technical skills were superb. I've stolen a lot of his practice. It would be like watching ballet, watching this man operate. He was just brilliant. Then I went to assist him in the private sector doing aesthetic work, thinking this would just be a mind-blowing experience because I was already very interested in aesthetics at that stage. And it was a totally different experience, and his mindset was just totally different. And he didn't really respect the patients. He thought that they were frivolous, and he didn't respect their needs particularly. And he was very much doing this because you can't make ends meet by resecting head and neck cancers, unfortunately, and that's the truth of it. So the sort of have-a-go cosmetic practitioner, now he didn't do it. He was a good surgeon, but I don't know if the patients received a total good experience going through his care. I sort of summarize these as specialists, but in an unrelated speciality. So I've encountered general surgeons doing facelifts. I've encountered anaesthetists doing liposuction. I've actually encountered, going to the next point, trainee anaesthetists doing liposuction, 2 trainee anaesthetists, one doing the anaesthetic and one doing the liposuction. Non-specialists, actually, I almost didn't put on this list at all because cosmetic surgery is not on the specialist register. So there are many non-specialists doing a perfectly good job. They've been doing it for years. They're not on any specialist register. They're not on the GP register, but they're fine. But I do see in the medical legal work I do that the non-specialist is overrepresented compared to a specialist in something. The non-specialists often find themselves working or more likely to find themselves working in the high street chains, which have their own setup difficulties with providing total care before, during, after the process. And finally, the FIFO surgeon, the fly-in, fly-out surgeon, or the overseas surgeon. I think they're very similar concepts, except the fly-in, fly-out surgeon essentially brings your overseas surgery to you. But in other senses, the difficulties with communication, aftercare, are much the same. Why isn't it letting me move on? There we go. So here's an example of someone misrepresenting their qualifications. I say I see this rarely, but this doctor is entitled to call themselves a cosmetic surgeon. But here on their website, they are also 5.5 years was in plastic surgery in the NHS. So that's, I'd say, an implication of them being a plastic surgeon, consultant plastic surgeon. It goes further on their LinkedIn page when they say they are a consultant plastic and cosmetic surgeon. Consultant plastic requires them to be FRCS Plast. There's no grey area on this. And you can very easily check this by Googling GMC LRMP. the General Medical Council list of registered medical practitioners. When you get there, you'll see a page like this. You type in that doctor's details and it will say, this doctor is not on the specialist register. This doctor is not on the GP register. They're absolutely not entitled to represent themselves in this way. And I'd say this is rare. I do always do a little check, but 99 times out of 100, there is no such misrepresentation. But you know, organizations are extremely clear that these titles have legal weight and cannot just be used flippantly. And in terms of causation, if the patient will say, look, I did my research and I wanted to be looked after by a plastic surgeon, and I saw this person was a plastic surgeon, and that's what guided me to have my surgery with them, then there could be causation there. The last thing, I guess, just to say about the practitioner is that a lot of, I'm generally appointed for the defendant. I would love to have more claimant work, but I'm generally appointed for the defendant. And I see, and it's quite startling, that I see the frequent flyer practitioner commonly, and I guess this quote is apt there, where the same mistake keeps being repeated. And you get some quite idiosyncratic technical surgical errors that keep being repeated sequentially. And you may have a practitioner with 3 or 4 cases of double bubble deformity, which is quite unusual, running simultaneously, or somebody ruptures a breast implant with a suture on closure. And you kind of just want to spend 5 minutes with that person, just say, right, at this point, just get a retractor, push the implant out of the way. It takes 5 seconds, it's easy, and that won't happen anymore. In terms of assessing a case, I don't know how much help this is to you, except that the hints are that the insurance companies will start to back off. They will start to reach their limits of what they're being covered for, and you might find someone, a defendant who is out there on their own a little bit, and then they're starting to look at what assets they have to cover a case. It's deeply unpleasant when it gets to that position. Okay, the other bit of the preamble is the institution. Now, again, there's confusion here because a strictly cosmetic procedure, which is not considered medical, does not require a medical facility. So it's outside of CQC registration. However, anything which does have medical value does need to be registered with the CQC. And there are some things which are ambiguous. So actually, things like botulinum or botulinum toxin injection is a prescription-only medicine. Filler injection is a better example. And filler injection, which is done purely for cosmetic purposes, can be done by a beautician, a non-doctor in a non-CQC registered facility. But if you are saying that it has medical value and you followed a medical pathway, then it becomes a medical process and does need CQC facilities. I suppose the acid test there is this practitioner expecting to pay VAT on the income they derive? You don't pay VAT on medical things, you do pay VAT on non-medical ones. So they can't have it both ways. They can't not be paying VAT and claim it isn't medical. So if you're not paying VAT, then there needs to be a really good reason why they're not CQC registered. It's important because, again, this is something that I tend to look up when I'm screening, because this is an easy win. Providing medical care in a non-CQC registered facility is a criminal offence with a £50,000 fine. And if a practitioner is caught doing it, they are going to want to get that case buried and settled pretty quickly, because there's more at stake for them. There's their entire GMC registration career at stake here. That is badness. And if the GMC catch wind of one of their doctors committing a criminal act, then they're bringing the profession into disrepute, and there's all sorts of bad karma about to be heaped on them. I've encountered people providing care in patients' home, and this is, in my opinion, just not appropriate. It's in breach of the CQC requirements. GP practices, GPs provide care, they do home visits, but there are special clauses written into their CQC registration that permit them to do that. The other examples I've come across are hotel facilities, and indeed an airport hotel. And we're back to the 2 anaesthetists, the 2 trainee anaesthetists, who are not only providing surgery and anaesthesia, but also doing it at Heathrow Airport in a hotel in the basement. So again, vigorously defended, as I guess they often are, but ultimately settled. And here's an example I have. This lady came to see a practitioner for a surgical scar revision, and the surgical scar revision culminated in this scar becoming that one. And there's lots of technical aspects of the way that this was conducted that were poor in the extreme. But the facility also wasn't CQC registered, and the scar revision is a medical procedure. So as soon as this was brought out, things came to a very rapid conclusion, because that doctor will not wish to risk a criminal prosecution. So the setting, I suppose we get on to the meat of it now, preparation for surgery, so the preamble. And for me, thinking about preparation for surgery is now about whether the patient is appropriate for the procedure, whether the procedure being planned is appropriate for that patient's needs, and whether the pros and cons, risks are explained to that patient adequately, so adequate consent. Now, in terms of patient selection, there's a huge range of acceptable practice, actually. We're used to making unwell people succeed in getting through an operation safely. So we can manage what would be considered relatively poor candidates if we consider it and make provision to do so. So it's pretty unusual for patient selection to be so poor as to be considered substandard, in my opinion. However, there are examples of that where patient selection is so very poor that it would pass the test that no reasonable practitioner would consider this patient to be a satisfactory candidate for this kind of surgery. And the kind of surgery we're performing is relevant because this is elective surgery. It is not mandatory, it's life-enhancing, it's life-changing, but it's not life-saving. And to actually impose a significant risk of death or other serious consequences on a patient for a non-life-saving procedure, it becomes a very, very difficult balance to argue. So we tend to select the ASA 1s and 2s. ASA is a classification by the American Standard of Anesthesiologists, as they call it, about risk of general anesthesia. Things that don't require general anesthesia, you may do in higher risk patients. So you're always judging the risk based on that patient's suitability for it. Patient selection may be based on physical or psychological grounds, not just physical ones. And psychological unsuitability, I believe, is quite difficult to demonstrate. It's not my place to talk about psychological unsuitability as a non-psychologist or psychiatrist, but we not uncommonly get the opinion of a psychologist or psychiatric expert. And again, even with someone with quite significant psychological comorbidity, I found that they're often reluctant to say that they're absolutely contraindicated for surgery. So that is, I'd say, less of a factor, but the physical unsuitability can generally be quite subjective and quite objective rather, and quite firm. And again, I'll give you an example of that. So this real case involved a 60-year-old lady who had a background of metastatic cancer, metastatic myeloma. In 2010, she was given 4 to 5 years survival and was on immunosuppressive chemotherapy, so serious medications. In 2015, so she's already technically on borrowed time here, she looks for cosmetic surgery. She goes to Belgium for this, and the implication, although this wasn't established, was that she couldn't find a practitioner willing to do it in the UK. She was assessed for the first time and underwent a major operation, a lipo-abdominoplasty, on the same day. In my practice, but not everyone's, a lipo-abdominoplasty involves a 2-night stay. In the majority of practices, it involves a 1-night stay. In some day case facilities, it involves a trip to a hotel close to the facility, a check the following morning. And those, say, are the range of acceptable practice. this lady with that comorbidity was helped off the operating table and escorted to the train station, where she then spent the next day on a train to the UK. Now, there are a lot of issues here. She had metastatic myeloma, so she with 4 to 5 years survival, and she's on immunosuppressive chemotherapy. So she's a poor candidate for any elective surgery. Anything that was not life increasing for her, I would suggest should be deferred, should not happen. There's no deferral here. She also got some very significant risk factors for infection. Myeloma itself is a neoplasm of the immune system, and she's on immunosuppressive chemotherapy. So if she were to have major surgery, there's a high risk of bad things happening to her in terms of serious infective consequences. And then on top of that were added additional avoidable risks for infection, such as letting this person go home with drains in place, which are a conduit for infection into the body, by public transport for a long journey, out of the range of the ability to follow up. I was quite critical of this, and I stated that my opinion was that the claimant was such a poor candidate for this surgery that she should have been declined it irrespective of how to go. And it is our responsibility as practitioners sometimes to save patients from themselves. And if something just cannot be done safely, then their willingness to, and let's be clear, she was absolutely willing to undergo this surgery. She wanted it, she sought it, she kept looking for people who would do it. So yeah, and it comes down to the balance of benefit versus risk. The risk was high. At best, if no adverse consequences whatsoever had happened, the benefit to her would have been a couple of months of her very short few months left of survival spent recovering and then dying. She was not going to enjoy the benefits of her abdominoplasty procedure, even in a best case scenario. Unsurprisingly though, the best case scenario did not happen. She developed a wound infection, which was beyond predictable, I believe, wound breakdown and sepsis. And this is the consequence. As a result of that sepsis, her chemotherapy, which was life extending, had to be discontinued because it was compromising the ability of the treating NHS hospital to deal with these consequences. It took 10 weeks to wound healing, and she died of her melanoma, of her myeloma, I shouldn't say melanoma, of her myeloma a few months later. So it was very sad and indeed, tragic. And this is a well-known surgeon in Belgium. There are those, for me, that's a gross example of the patient being absolutely unfit for this kind of surgery. Now, I actually can't see my title because I have my own thumbnail in the way of my procedure planning. So in terms of the preamble to the procedure, one thing that needs to be done in the Montgomery era, the post-Montgomery era, is that all reasonable treatment options need to be discussed, and treatment options that the patient would consider relevant to them, even if the practitioner doesn't think they're good options. And it's okay for a practitioner to choose a reasonable option that is not, for a patient to choose a reasonable option that is not the practitioner's preferred option. In fact, that happens not that uncommonly. And I almost think that that's a good marker of impartiality on the part of the practitioner, that some of their patients will choose something that they didn't want you to choose, but it's, at the end of the day, if they understand the risks and benefits, it's their choice. It's not the practitioner's choice. In my practice, this often happens with breast implant size choice, and I really try to keep my biases out of things completely because it's not my body and it's not my preference that's relevant. I like to give people the range of options that will physically work for them, and then it's over to them. I tend to go somewhat smaller than the patient does, but I keep it in my head. So that's okay. There should be 2 consultations and there should be a 2-week cooling off period. That's a should rather than must. This isn't enshrined in law, but it is promoted by, it is recommended by a number of very august bodies for this kind of work, for aesthetic work. notably the British Association of Aesthetic Plastic Surgeons and the British Association of Plastic Reconstructive and Aesthetic Surgeons. And if these are not adhered to, I am less critical in defendants who are not members of those bodies than the ones who are, because membership of those organisations suggests that you are, the safeguard to the public is that they know that you are going to abide by their recommendations, and if you fail to do so, then I think that is in some way misleading. However, it's often causatively not very relevant, I have to say. The last thing on the angel side of this guy's shoulder is consent as a process. Consent is not a moment in time. Consent is not a piece of paper. Consent is conveying all the information that the patient requires in the manner that they need to consume it, in the time that they need to consume it, in order to make an informed decision. And there are tests for whether there has been adequate consent, or even whether a patient is capable of providing consent. And on the other side, the single or short preoperative consultation without a calling off period. And I cannot communicate all the things, my consultations were pre-COVID 45 minutes, post-COVID they're 1 hour. And I have 2. And in that 45 minutes times 2, or 1 hour times 2, plus a lot of paperwork, sent as homework to the patient, I really struggle to convey all the information that is truly required for them to make an informed decision. It's challenging. So when I hear about the 10-minute consultation, I am staggered that there is any kind of process by which the information could possibly have been adequately conveyed. But that is then tested when we sort of question the parties involved. One typically sees a lot of delegated planning, and that's one technique that can be used to abbreviate the consultation with the practitioner themselves. And there are patient care advisors, salespeople often, and I see quite commonly a patient care advisor come up with a provisional plan that then gets passed to the surgeon for their approval. But what doesn't sometimes happen is that there is not adequate scrutiny of that plan by someone who is ultimately not a healthcare professional. They don't have qualifications. And even though that could be helpful, it could provide the patient with more time and more information, the plan has to be right. And I think it's Tim Ferriss who says it doesn't matter how good a cook you are if the recipe sucks. So you can do the wrong thing very well and get a bad outcome. But actually, if you do the right thing in a sort of middling kind of way, you'll get probably an acceptable outcome. So that plan has to be right. Excessive preoperative reassurance, we'll talk about that a bit more in a bit. In fact, I'll talk about all of these a bit more, so let me just move on. Yeah, so I've talked about this already, the single preoperative consultation with no calling off period. I say it's not causatively terribly strong often because it's rarely a concern to the patient. And when they're questioned and tested, they will often say, if I'd had longer, if I'd had 2 consultations, I probably still would have gone ahead, actually. I've been thinking about this for a long time, so that I can't honestly say that I would not have proceeded if I had had more time explained to me. So they're often surprised to know that that's what the guidance was. And I consider it poor practice, but it's often causatively lacking. Delegated planning could contribute to a case based on whether consent was adequate or not, and whether the patient or the claimant can demonstrate that risks were not conveyed to them fully. But again, actually, this is often not. If this was a case in isolation, it would be a relatively weak case. I don't think I've seen any cases swing on the fact that part of the consent process was delegated. Now, this is a point that has dawned on me, I'd say, in the last year or so. And there are, I think, 2 kinds of practitioner out there. And there is the one group of practitioner who say it like it is, warts and all. They are painting the gloomiest picture of a procedure outcome. They are saying they're at these risks. And when the patient says back to them, yeah, but that's not going to happen, right? So no, it could happen. Honestly, I'm not saying this, I'm not just spouting hot air. This is a risk and it could happen to you. And you've got to accept that risk happening. And if you don't accept that risk happening, this surgery is not for you. And it's unlikely, statistically, it's probably not going to happen to you, but it might do. And if it does, here's how we'll manage it, and here are the consequences, and so on. And then there are the other groups of practitioner who reassure, who do the opposite. It will all be fine, everything will be fine. And I guess here's an example of that from a case I've been involved with. It is such and such evidence she would not have proceeded if she'd been advised that an uplift was necessary. And this is the avoidance of the uplift and doing the augmentation on its own. It was reportedly assured that she was a perfect candidate and that, you know, it was very gushing, could achieve a really great response and everything would be wonderful and perfect. And I hear that, and even the P word alone, I shudder to say the word perfect. There is no perfect, and people need to be disillusioned of the fact that there is such a thing as perfect. And what has dawned on me is that the good practitioner's biggest medical legal risk, or the biggest risk of dissatisfaction, certainly afterwards, is of unmet patient expectations that were too high, and so despite providing good care, those expectations haven't been met. And it is they have learned to do everything they can to lower expectations. So, you know, this could happen, that could happen, it really could happen. If it happens, we're going to do this about it. You might have further procedures, you might have revision surgery, you know, actually get those expectations to a realistic level. Whereas the practitioner who is commonly seeing mishaps in their practice, who is commonly seeing complications, their biggest risk is the patient actually reasonably being concerned about the outcome of those complications happening, and therefore not wishing to go ahead. So they've got a business risk. And so from their side, they need to get people, you know, they need to keep the conveyor belt moving by providing reassurance, potentially, you know, without justification. And so you seem to see, you know, for me, it's an alarm bell when you sort of see all the, you know, really reassuring preoperatively, such and such will not happen. None of us can say that such and such will not happen. I can tell you that in my practice, I've had breast hematomas ever, so it's unlikely, but I can't say that you won't be the third. I can tell you that I've never had, fingers crossed, I've never had a serious infection, you know, and by which I mean an infection requiring hospitalization or debridement, but you could be the first. And it's not uncommon for me to say to patients when something happens, I'll say to them, I can no longer say I have not had such and such complication. And I'll say, well, okay, you told me it was a risk, and there you go. And from then on afterwards, I say, I have had one episode in which such and such has happened before. And incidentally, when a defense about poor consent is often that the patient had seen another practitioner first about a similar or the same procedure. And I don't think that is sound, because every practitioner's complication profile is different. And I can tell you that in my hands, such and such is unlikely, but I know that in another practitioner's hands, double bubble, which I never see, has an almost 100% incidence. So, you know, me telling someone that bubble is almost certainly never, you know, not going to happen does not apply to them going to another practitioner with a different technique. And if they accept that, then it's okay. But if they presume that practitioner had my complication profile or vice versa, then it's not necessarily okay. Now, here's something that is common, particularly amongst the sort of high street chain cosmetic institutions and practitioners in them. Things are very protocolized to try to prevent things being forgotten. And you can often see these massive checklists, and they're all, you know, duly ticked. Yes, I have done everything I need to. The trouble is, they've all been ticked, but in this particular case, implant rupture refers to an implant displacement refers to a breast implant life, etc. This patient was having a breast reduction, which kind of shines a light on the fact that this was not representing an adequate process. I think a judge would have difficulty being persuaded to accept that this person, this practitioner, had really said your implants may rupture, had really sat there and explained that, and then ticked the box, and the patient had not failed to respond, but I'm not having implants, and had then gone again to say it again, your implants may get displaced, without them saying, I'm not having implants. Your implants will have a certain lifespan, tick. You know, all of these things, capsular contracture, muscle indentation in the submuscular part, they were all for the wrong operation. And this kind of points to an inadequate consent process, despite what on the face of it could have been a very good one. So caution needs to be engaged. And I was asked about this, and the response from the defense team in this case was, well, okay, we can potentially accept that some risks that were not relevant were explained, but do you not accept that the risks that were relevant also were explained? To which my response was actually, no. In my opinion, the process was poor. Consent needs to be a means of communicating risk to a patient in a way that they'll understand. And it has to be procedure specific and indeed patient specific. Now, if it was enough just to let every patient know about every risk that exists in every case, then I could just produce a book, a little, you know, pocket dictionary sized book of every complication that exists, defined, and say, there you go, have that, read it, yours are in there. But they are not getting meaningful, personalized information for them, and they will lose the wheat amongst all the chaff. So no, I didn't agree with that line of reasoning. There's another example, consent as a moment. What do I mean by that? Well, there's a patient who had been provided really with no preoperative counseling, except on the day of surgery, about to go into surgery, when they are provided with an extensive 23-page consent form, which was indeed procedure specific. It was full of medical jargon. It was difficult for me to read it and understand it. And I took, knowing all the terms and knowing what they all meant, I took half an hour to read that. I said it would take around an hour for the lay person to read it, but I think that's under-egging it. I think most lay people would probably take most of the afternoon and would struggle with that document. And, you know, my position on that was that that patient has not received adequate guidance as to the likely risks of their procedure in a timely way, in a manner that they are reasonably likely to be able to digest. And that was very much their recollection. They said, I was handed something, I had to sign it, so I signed it. That's not consent. And the way I sort of summarize this as a concept is sophisticated medical legal defensiveness amongst practitioners. So your quote's good, not wishing to generalize too much, but your quote's good practitioner manage their, and we're all aware of medical legal risk in what we do in aesthetic surgery, but manage that risk by actually trying to implement systems and processes that give them good outcomes, that give them happy patients, that give them good outcomes. Whereas poor practitioners seem to manage that risk by seeing their risks and kind of trying to contractually extract themselves from them in some way. So I will see, for example, there's a couple of practitioners doing the rounds at the moment who are making their patients sign non-disclosure agreements to any outcome that they have had that they are unsatisfied with, particularly on social media. And that's because the bulk of their work is derived through social media. So there are some Facebook pages, some closed pages, and anything negative means that they are given a sort of a nominal discounted fee. So they're quoted, I don't know, £15,000, but they pay £4,000. But if they break their NDA, they have to pay the difference, and so on. So there's this group of terrified, very unsatisfied patients. I suspect that those contracts or agreements are not legally robust. There was no recommendation that they seek legal advice before signing them, but the patients don't know this. And so on. It's this sort of very sophisticated medical legal defense, and I think of huge checklists and onerous consent forms as being part of that. And, you know, it's my practice. It's not what everyone does, but I kind of like to drip feed patients with information, knowing that they cannot retain everything. And one thing that's been brilliant during COVID is the rise of the remote consultations that we can record. And at the end of the consultation that I've recorded, I will then share the link to the record with the patient, and they can replay that consultation as many times as they like. And there is no disagreement. There can be no disagreement about what was said and what was not said. And some people feel vulnerable. I think if your practice is good, I mean, yeah, sure, it could place you at vulnerability as a practitioner, but it should do the opposite, and it should actually be a way of evidencing your good practice. So I think if you've got nothing to hide, one should hide nothing. Right. The conduct of the procedure now, how the surgery is actually done. Procedural issues are really common, but commonly coexist with one of these other two, usually B and D. What do I mean by that? Well, aesthetic surgery in particular is not, there is not one way of doing it. There is variation. There is actually some artistic variation, which is one of the things I love about it. And there is variation that I would call justifiable within the scope of accepted practice. And there can also be good outcomes, but the difficult patient and the patients whose expectations haven't been met despite a good outcome. And really despite that practitioner's best efforts to screen out people who could be anticipated to have an unreasonable outcome. And we all know these patients, that some of them will sort of turn on you afterwards, and they will seem the loveliest, sweetest, most reasonable people before surgery. And it's the sort of bridezilla but applied to cosmetic surgery concept, in which suddenly you'll just be absolutely lambasted with someone who's, who really gets you out of left field. And that can happen. Then on the other side of it, there is the unjustifiable variation in surgery, where something different is done from what was agreed, what was frankly agreed and explicitly agreed, without any intraoperative basis for that, and without being able to have reasonably predicted from the outset that that difference would have been necessary. Then there are the reasonably unmet expectations. So the patient's dissatisfied because too much or too little has been done. Now, if you look closely enough at any outcome, especially a subjective outcome like this, always too much or too little has been done. There is no, if you look with a close enough microscope, yesterday I was doing someone's eyelid surgery, for example. They're either not going to be able to close their eyes, or they'll have a little bit of skin excess at the top. There really isn't a middle ground there if you look hard enough. But so when I say reasonably unmet expectation, I mean far too much or far too little, in which there is really, that is outside the range of what one would consider an acceptable practice. And actually, I consider as acceptable outcomes that would be considered a bit average, a bit mediocre, not great. You wouldn't use them to promote yourself. They're not great, but they're not, not substandard. They're just meh. Whereas the ones that are really off the wall are the ones that get criticism. And finally, there is sometimes surgery which is conducted technically incorrectly, and we can say this objectively. And that's quite rare, because the standard of documentation is not normally such to be able to give us that level of detail, but it sometimes is. And I've got an example of that here too. Right, so that is that example. So here is an operation note in which the procedure conducted was a dual plane bilateral breast augmentation. A good operation, and it was described in 1999 by this guy called John Tebbets, which really changed a lot of how breast augmentations are done. Previously, they'd been either submuscular, under the muscle, or subglandular, above the muscle. And this is a kind of component of both. And what it says, his emphasis, selectively dividing the inferior origins of the pectoralis along the inframammary fold only, with no muscle division along the sternum, helpfully emphasized by Tebbets in the paper. And here we see operation performed. And where is it? Pec major elevated and detached inframedially, that's correct. And from ribs 6 to 4 parasternally. So running up the outside edge of the sternum and detaching the muscle, exactly as Tebbit said not to do. And there's good reasons not to do it too. So that is one way you can say, I'd say on objective, strong grounds, that operation has been done wrong. You said it's dual plane, you've done this, and you shouldn't. Then there are others, and this is a lady who had a periareolar mastopexy, a mastopexy conducted around the areola, using a suture that was not going to hold the tissues for long enough to avoid stretch. So what happens is a reasonable outcome actually at first, you know, except it's not great, but it's acceptable. And then you get areolar stretch very rapidly. If you look at the dates, the timeline here, we're going from May to October 2016, not a reasonable longevity of this result. And again, you know, my position was that this was technically incorrect. And I don't know how squeamish you are, but this is, oops, sorry, you've got the volume. This is how you do a periareolar mastopexy. It's one of the most fun things I do. It's a really satisfying operation, but I won't give you too much of that. And it's not that common. You might think, but I'm an expert for the defense. It's pretty uncommon for me to then do any corrective surgery for that defendant after their case is settled. I actually quite like to avoid it, but I do sometimes do it. And I did do it in this case. And it is perfectly possible not to have a stretched scar, contrary to what the defense position was throughout that case. And it's perfectly possible to have good longevity of a result. And it's perfectly possible to have an adequate, you know, it wasn't just the patient's fault as was being put to them. And I kind of like to see this because you can hear such strongly worded counterpositions to your own that you can sometimes think, am I going insane here? But it's absolutely, with the correct technique, it's a very predictable, safe technique in the right person. Now, I'm cautious about extremely fast or extremely slow surgery. Extremely fast surgery can be the marker of the expert. So here, if we say, this is very unscientific, but if we say this is a baseline, a normal surgeon doing surgery, this is how they prep, this is how they do the operation, this is how they close. A master often spends longer prepping. I've observed people who I really consider a master's for facelift surgery, for example. I went and watched the guy in New York who's done 6,500 of them, and there's not many people who can say that. He took longer in the preamble to surgery than I do. But then the surgery itself was much quicker. His closure was a bit longer. He spent longer on the closure. Couldn't believe it, but his surgical times were shorter and he was more efficient. The junior surgeon, the inexperienced person, is just generally slower at everything, with similar proportions though. But here's the corner cutter, the person who's fast, very fast, despite not being an expert. And they kind of spend about the same time doing the preamble. They actually spend a bit longer doing the surgery. And then they close really fast. Now, it's not for fun that at the end of one of my thigh lifts, I then spend an hour and a half closing the skin. There's a lot of upholstery in a thigh lift. There's not a lot of upholstery in a lot of the stuff we do. But to do it nicely in a way that will give you the kind of wound outcome, scar outcome I was showing you before, does take that time. Now, I could rattle staples through that wound in 5 seconds like anyone else, and I'd be closed and gone and on to the next case. But the patient would predictably have a terrible outcome. I'm sorry, staples in an aesthetic field, I will never find acceptable. I don't care what papers from the gynecology literature one finds that tell me a gynecologist closing a cesarean section does as well with staples or sutures, because no one is as concerned about the outcome of their cesarean section scar as they are about their breast scar or their facelift scar or even their abdominoplasty scar. Now, here is an arm lift. And here's an example of too little. And this patient, she's quite chirpy about it. She's got a big smile on her face that I'm concealing there, but she's saying, look, I hope it is self-evident, she is trying to communicate here, that this is not a good enough arm lift. And so she had a revision arm lift. And unfortunately, at that point, too much was taken away, such that the arm turned purple and was losing its blood supply, and some of the skin that had been removed had to be replaced as a skin graft. And then left her with this extensive scarring that's actually now almost impossible to reconstruct. And the thing with this is it gives you objective measures of how much too much was taken. That's a 10 by 16 centimeter skin graft. So 16 centimeters excessive width has been resected. And again, I'd say that is outside the range of acceptable variation. And actually, you know, that situation was a lot more defensible because that that may have been within the scope of accepted practice. I really have to consider that, but that I'm afraid is not, in my opinion. Okay, common examples. The surgery not being agreed. Sometimes someone will say, we'll do such and such type of liposuction and then changes it. More of a contract issue if the outcome is the same. Sometimes someone will agree on shape or size or plane of breast implants and then change their mind. Or it can be a different procedure subtype. For example, I've seen people saying, I will do a vertical scar mastopexy, probably without much experience of vertical scar mastopexies are the most challenging type of mastopexy. And they may have, in the time between committing to that with the patient and doing the surgery, done a little bit more reading perhaps and realized that they were a bit out of their depth and then changed their mind. That just needs to be communicated to the patient. You just need to eat humble pie and communicate. I'll go on to this one, abdominoplasty type. There are different kinds of abdominoplasty. I'm aware I'm running short of time. How are we doing, Dominique?
Doing fine, don't worry.
All right. There are different kinds of abdominoplasty, and the mini involves essentially a small scar with a melon slice of skin removed. The full, if you imagine that melon slice of skin exceeds the belly button, then you'd be pulling down the belly button, enclosing that wound, down, so it was down by the person's naughty bits, which is not a cool look. So in those circumstances, we need to actually cut the belly button stalk away from the skin that it was previously attached to, and then bring out a new aperture for it, which is why there are two scars with a full. And then there's a fleur-de-lis, which is the transverse with a midline scar too, for very extensive skin resections in a side-to-side direction as well as up-down. Now, here are some examples of mine, and you can sort of see, you know, the kind of example, you know, the kind of patient and the kind of scar pattern. Now, this lady wanted a full abdominoplasty, and the surgeon very reasonably suggested that she could do with a mini, and was quoted for a full and a mini. Now, the patient came back and said, I really want a full abdominoplasty. The surgeon, again, very reasonably said, if you go for a full, you may have an additional scar. And the reason for that additional scar, if I run back, is if I can excise to about here, but I can't remove the bit of skin that now has a hole in it because I've cut the belly button stalk out of it, then this skin is pulled down and you're left with a bit of skin with a hole in it that you have to close. And that's usually closed by joining that scar onto the main one as a little vertical scar, or indeed a little horizontal scar parallel to it. And so this surgeon recognized that this is a trim patient without much excess skin, and they're actually probably not going to be able to excise all of that stuff. So that's what they've planned for with their full with an additional scar. The patient accepted that, and they paid for the full, not the mini. So it was very clear from all parties what was going to be done. The operation note was then abdominoplasty modified, and the patient could smell a rat because things were then weird afterwards. Very, very, very tight below the belly button. No increased tightness above the belly button at all, as if the belly button hasn't been detached, as in a mini abdominoplasty. But there is a belly button scar in there when you look closely. And it turns out the patient has had a sham full abdominoplasty. It was a mini, but with a belly button scar. And how can we know this? Well, you can know this because before surgery, the patient had this freckle there, that freckle there, and an umbilical piercing. After surgery, now with a belly button scar, they still have this piercing there, that piercing there, and their belly button piercing has not been removed. So there has been no relative movement of the position of the belly button on the skin of the surface of the abdominal wall. Therefore, a mini abdominoplasty. And that scar has just added injury and has actually precluded her from having some of the revision surgery she could have had in the future, unfortunately. So again, this is one that settled. Oh, finally, the tattoo remnant even was evidenced a skin excision consistent with the mini abdominoplasty, not the sort of limited full abdominoplasty that had been planned. If you look at what's left behind, this bit of this sort of funny flower here is still present, whereas it would have been absent if the plan A had been followed. So yeah, and there were several consequences of this that were adverse for the patient. Finally, I'm getting there. Aftercare. And aftercare issues can relate to failure to recognize a complication or failure to manage a complication. And I mentioned that some of the way that some of the change practice are set up really hinder the surgeon in being able to recognize a complication, because they are not given the opportunity to follow their patients up. In fact, the surgeon, it sounds like quite a tempting offer. You're given a sort of lovely central London location to work from. You are told that your clinics are going to be filled for you, which is one of the biggest challenges, and you just get a fixed fee, and it's a pretty modest fixed fee, but your operating lists will just be jam-packed. You don't have to follow up the patients afterwards, and if you're this is thankfully one of the mistakes I was able to learn vicariously from medical legal practice rather than ever having done myself, because you get these offers and they sound quite tempting, but actually the person left holding the baby for complications is the surgeon. It's not the chain. The chain's legal responsibility is generally to provide a surgeon and facilities and nursing care, which they do, tick, tick, tick. It's the surgeon's responsibility to manage the patient. And if that surgeon is not in a position to recognize that complications, if things aren't communicated with them, well, they are actually still responsible for their patient. They've taken on a duty of care, and they need to organize their practices in a way that they can recognize these complications. So good care, complications are recognized. Risks of complications are preemptively advised to the patient when it's reasonable to do so. Reasonable, likely, risks that we're familiar with, yes. Effective management is implemented when something bad happens. The consequences of that are minimized, and the relationship is maintained in the way that I was telling you of that patient who said to me afterwards, and she sent more patients my way. When the first person came to me and said, oh yeah, and recommended to me by such and such, I thought, that poor lady who had all those issues. But it's just a sign of, she told me I felt cared for the whole time. And she actually had a nursing background, and she sort of did also appreciate that these things can happen, I guess, better than many. Versus the complication not noticed or not managed, or managed in an inappropriate way. And if you see a surgical wound breakdown, and I call a surgical wound breakdown one that will require surgery to bride the wound and close it again. But if you're the nurse in a hospital looking after this patient with a surgeon who is unavailable to you, then you will manage that with dressings for ages. And after ages, it will heal. A year, 2 years, it will heal. I've done some charitable work in Sierra Leone, and I tell you that there is, a healthy patient with enough time, most things will heal, but it doesn't, I've seen a cobra bite on the back of a hand that left a huge defect, and it healed, but it healed with the person's back of their hand fused to their forearm. So the fact that something heals is not an indicator of success. That would have healed better with proper management. And it can be little, no delegated follow-up. Delegated follow-up is okay as long as it's appropriately delegated with a means of escalating back to the surgeon if you need to. There are typically secondary and tertiary complications resulting from this. Prolonged care. There can, in some cases, actually be surgical revisions, and in those cases, as much care needs to go into the whole process, preamble, technical aspects, and aftercare, as with the primary surgery. And what's commonly done is the whole consent is glossed over for the revision. The revision is not well considered, and it's therefore not a success. Revision surgery is generally more challenging than primary surgery. So if you take a less robust approach to the revision, then you're setting yourself up for failure. And then another characteristic is poor communication and stonewalling the patient, and what I call either active or passive stonewalling. Active stonewalling is where the patient's trying to get somewhere, trying to communicate and failing to do so. And passively, actually, the patient has lost faith in you. They don't want anything to do with you. And the surgeon, on the other hand, is thinking, thank God for that, because I don't want to see them either. The passive stonewalling. And one of the things that was drilled into me at quite an early stage is when you have a complication, you've got to make that person your best friend until it is dealt with and they're really happy. You've got to smother them in love. You've got to be offering them reviews and appointments and reassurance and message. And you've just got to absolutely, smother that problem with love. And that patient feels cared for and looked afterwards. Now, complications are okay. I kept saying this. They can happen. They should be anticipated. And surgical complications require surgical management. And eventual healing does not justify a non-surgical approach, I believe. The kind of complication that happens in this way is often a hematoma, infection, or tissue necrosis. An expanding hematoma, for many reasons, which I'll happily elaborate on, mandates, not too strong a word, mandates surgical exploration. And again, vicariously through medical legal work, it's been interesting to observe the natural history of untreated expanding hematomas, but it is never pretty. An infected foreign body mandates antibiotics and removal of that foreign body. An infected breast implant does not get better except without removal of the implant. I have heard of exceptions. Some of us in surgical forums and groups and meetings talk about the exceptions because they're such exceptions, you know, such and such, they had this infection, exposed implant, they did it and it healed. Wow, that's rare as hen's teeth. And if you want to get it right, 100% of the time, you've got to remove that implant when that happens. And if you want to get it wrong, 99.999% of the time, then you can try to treat it non-operatively. If you're going to treat it non-operatively, you've got to be all over that patient and be prepared to change your mind because you've probably made the wrong call. And tissue necrosis, dead tissue, unless it's extremely minimal, does require surgical debridement to get that wound healed in a timely way. Now, eventually, yeah, the body will evacuate, it will slough it off, it will scab away and come away. That will take forever, depending on the size of the wound. So another example, this lady, 29-year-old dancer, exceptionally fit, had an augmentation mastopexy and thigh liposuction in Poland and became very unwell. I'm going to race through this history, but she became obviously septic. To any doctor, and I think most non-doctors reading this, the patient is obviously septic. And she kept reattending the clinic 5 times in 4 days, increasingly severe symptoms, eventually discharged. She was actually rescued. Her life was saved by her mother flying out to that country and getting her on a plane. She was met at the runway at Heathrow by ambulance, transferred straight to theatre, do not pass go straight to operating room, straight from theatre to intensive care, from intensive care back to theatre 4 or 5 times. She was on death's door. I told you she was very fit. That is the reason she is not dead. She's 29 and not many people would have survived the degree of sepsis she was in and multi-organ failure that she sustained. This is the result of the debridements. It is not what she was hoping for with her breast augmentation. She is a dancer who, it's a slight euphemism, her breasts are mission critical for her employment. This is not the outcome that she was hoping for. So, finally, common themes relate to poor selection of the practitioner by the patient, poor selection of the patient by the practitioner, or generally poor preparation for surgery, poor conduct of surgery, or poor aftercare. And if those things are got right, then most patients are happy. But those are the themes to look out for. The red flags that can signal, you know, badness in a case can be, and of course not always, you know, it's possible to have a very fast surgeon who's just amazing, but most very fast surgeons are actually not amazing. There are very, everyone thinks they're above average, but statistically of course it's not correct. Surgeons are probably of the personality type that are more prone to thinking they're above average, so don't take their word for it. But the overseas surgery or FIFO surgeon, the very short single pre-op consultation with no calling off period, delegated care, excessive reassurance, huge checklists, massive consent document, objective knowledge gaps. I'm referring now back to that dual plane operation as an example, little, no, or delegated follow-up, prolonged wound care. These are all signs of a general, you know, not having systems in place to manage patients through this process and get them through the other side safely. And that's about it. So that's the end of my presentation. And gosh, I'm just going to check if there's the same number of participants at the start. Yeah, not quite, but actually not bad. So thank you very much for bearing with me.
Thank you, Fulvio. That was so insightful. We've just got, if you've got time, just for 1 or 2 questions that have come through.
Sure.
One is about aftercare, and it says, if an independent surgeon is working for a clinic with practicing privileges, does the surgeon bear some or all of the responsibility for seeing that patient post-operatively, even though the administrative side of booking the post-operative appointment is carried out by the clinic?
Yeah. So what is interesting is that the clinic, I'm not all, I mean, I've done a few hundred reports. I'm not aware of the clinic ever being ever being successfully litigated against. They often start the process as a co-defendant, but I've not seen them end the process as a co-defendant. So it's difficult because you're right, the administrative processes are set up such that that surgeon has no part in that aftercare process. And yet they are left carrying the baby, they are left holding the baby on that one. And so that surgeon is in a difficult position. They need to organize themselves in a way that they are available should the need arise. And they need to make it very clear to the nursing staff to whom the after is delegated that they are available. I mean, I've spoken to colleagues who have had issues and they say, oh yeah, but it's with such and such clinic. So, you know, it's going to be their responsibility. And, you know, I've sort of said, actually, that's not usually how it works out. It's your responsibility. So professionally, they need to implement systems that mean that things can be escalated back to them. And it may just be as simple as telling the nursing staff in the dressing clinic, look, if you've got someone you're worried about, here's my phone number, here's my email address, you can always get me, or you can get my secretary who can get a message to me. And then when that message comes through, arranging to see them again personally. So yeah, I'm afraid they are responsible. They do retain responsibility. The clinic is, I'm pretty sure, for their own practice and their ability to practice in the long term, they need to have something in place to look after their patients themselves. And it may not be called on, and that's okay. It's okay for there to be routine follow-up done by a nurse, by a clinic. And, you know, that surgeon may never see them again if that's how they want to run their practice. And if everything goes fine, it's fine. But it's the cases where it doesn't that they need to be able to step in.
And there's just one more, if that's all right. Someone has messaged, this was a question that also arose prior to the webinar about issues of concerning poor consent with fat freezing procedure. And I just wonder what your view is there any red flags that we should be looking out for in respect of consent with those types of procedures? Yeah,
I've got to say the non-surgical side of things is a lot less regulated. And I would say it's probably a lot less clear. The non-surgical practitioners who are taking it seriously treat it exactly in the same way as a surgical procedure. So there's a consultation, but not two actually. It's generally a consultation in which risks are explained, a consent form that is signed. But actually you will find, I believe, you will find exceptions to that practice within the accepted range of practice. So it's more difficult. But even if a form hasn't been signed, and I think it should be just to document that this discussion has happened, but even if the form hasn't been signed, there needs to be this discussion of what the risks are. Probably the most serious risk with fat freezing is this paradoxical adipose hyperplasia, which is a risk of your fat cells responding to freezing by expanding rather than shrinking and dying. And obviously that's a disastrous outcome if it happens. And there needs to be some form of consideration as to how it's going to be managed if that's the case. So I have a clinic and I actually have got fat freezing machines and we think they're great. If that were to happen, if a patient were to get PAH, the company that, so Allergan in this case, I've got core sculpting machines, will actually fund the PAH revision treatment. They've said that they just want to manage that complication in that way. And the revision treatment would be liposuction. And in my case, although I don't deliver core sculpting, I would deliver the liposuction to address it, which would be done with all costs met by Allergan and any other costs waived. So that's how we would manage it. But it's reasonable enough to say, for an institution to say, you may get PAH, and if it happens, then you have to sort it out yourself, and you may incur additional costs of doing so. But that conversation needs to be had. And different practices will probably charge different amounts for their fat freezing, in part based on what those policies are. So the patient needs to know those policy differences in order to make an informed decision. Some will be happy to pay £100 less, but not have the safeguard of their PAH being treated for them if it were to happen. So that's a 1 in 10,000 risk actually, so it's pretty low. Were there any other specific risks of fat freezing? The other one, I suppose, is the risk of it being either ineffective or of it not having as much of an effect as someone would want. Again, places will have different policies on how they manage that, and that will just have to be communicated. And we tell people that if they literally believe, and we believe, comparing the pre and post photos, that there's been no effect, then we would refund their treatment cost, or we would give them further treatment for free. Or if there's been an effect which is there but less than they wanted, then we would discount further treatment. That just happens to be our policy on this. But it just needs to be communicated as to what you will do under those circumstances.
Thank you. I think that's probably, considering the time, all we've got time for today. But thank you so much for everyone joining, and thank you, Fulvio, for your presentation. It's been really, really insightful, and I hope everyone learned a lot from it. I certainly did.
Okay, great. I've just stopped showing my screen, so I can now see all these Q&As too. So I will respond to some of these. I'll just sort of type some responses to these too. Perfect.
All right. Well, thank you everyone so much. It's been a pleasure.
Thank you very much for coming along as well, and thanks for inviting me. I really appreciate it. And sorry for the overrun.